Hello, I'd like to welcome you to Columbia Ethics Grand Rounds. I am Meg Menzel, Assistant Professor in the Division of Ethics at Columbia University Irving Medical Center. I'm absolutely delighted to welcome you to today's Grand Rounds entitled In a Post-Dobbs World, Ethical Challenges from the Perinatal Perspective. For those of you new to Ethics Grand Rounds, this monthly series is organized by the Division of Ethics in the Department of Medical Humanities and Ethics at VPNS here in Columbia. The goal of Ethics Grand Rounds is to engage our community of health professionals, scholars, scientists, and trainees across career stages and disciplines by centering important topics and debates in medical ethics that relate to clinical practice, research, and education. Before I turn to our topic today, I'd like to remind our large audience to please check the chat for logistics and other information for this session. Following our speaker's presentation, we will move into the discussion portion of today's session, where we'll accept questions from the audience. Today's session is being recorded, and the recording will be updated as a resource to the Columbia Division of Ethics website following the event. Now to the focus of today's Ethics Grand Round, perinatal ethical challenges in the post-Dobbs landscape. It has been almost 4 years since the Supreme Court's 6-3 ruling eliminating women's federal constitutional right to abortion. Since then, we have watched entire medical systems in some states change how they care for women and children. We have heard countless stories of moral distress from providers who have been asked to deviate from standard of care in order to keep their jobs. And we know of too many examples of women who have been denied the obstetric and reproductive care they need in the states they call home. Today, we will have the opportunity to explore some of the downstream ethical challenges presented to perinatal and neonatal care systems and families since the Dobbs decision, including considerations around viability and quality of life. Although these challenges are not new to perinatal and neonatal medicine, the pathway there for many is now paved by the Dobbs decision. Understanding these potential scenarios, in particular for the most vulnerable, is an important step in supporting our patients and providers as we continue to navigate this divided landscape. Today, we are joined by Dr. Alaina Pyle, Assistant Professor and Neonatologist at Connecticut Children's Hospital, where she works closely with the Pediatric Ethics Committee and palliative care teams, and where she is a primary member of the Fetal Care Center, providing multidisciplinary consultation for complex fetal conditions. Dr. Pyle has completed the certificate program in pediatric bioethics through Mercy Children's Hospital and will be completing her Master of Science in Bioethics through Columbia University this summer. I'm incredibly pleased to welcome Dr. Pyle. Thank you.
Okay. Make sure I can get this working here. Oh. 1 second. I just have to push harder. Okay. I was trying to do the arrows. Okay. All right. Back in business. So thank you so much for that introduction, and good morning, everybody here in the room and online. And thank you to the Columbia Division of Ethics for the opportunity to speak with you all today. First, I do not have any disclosures that are relevant to the talk I'll be giving. I do want to put out an acknowledgement to my co-authors for the paper that was behind a number of the topics we're going to talk about today. It's just a wonderful group of co-authors, and I really enjoyed working with them to develop some of these ideas. So we're going to try to cover a lot of ground today in a pretty short time. Some of the objectives I hope to meet are to review some of the historical background, some of the relevant court cases that led up to the Dobbs decision, and use a case to really show some of those impacts that we see in the perinatal care and postnatal care space. We'll look at the impacts post-Dobbs on the perinatal timeframe as it is meeting at the crossroads of obstetric, neonatal, and surgical ethics. And we're going to also highlight some of the potential exacerbations of healthcare disparities that already exist. Before I really dive in, I just wanted to pause a moment and preface with a couple points. This is a really hard topic. There are a lot of people who have very strong feelings about abortion and reproductive choice. And I want to emphasize that there are very smart, kind, reasonable people who can and do disagree on this topic. And it's really important that we sort of approach these conversations with an open mind and curiosity and trying to think about different perspectives and how different decisions might impact those perspectives in both the short term and the long term. So I always like to say first, I am not a lawyer, I'm not a legal scholar, but I think it's really important to understand some of the history where we came from as a country. So if we go all the way back into 1873, that was one of the first legislative efforts to look at contraception and abortion. So the Comstock Law was passed by the US Congress in 1873, and they made it illegal to distribute or sell materials promoting contraception or abortion. There were, over the next 50 years, from 1850 to 1900, essentially every state in the US passed laws to ban abortion in different ways, but pretty universal. Only exceptions were to save the life of the mother. I picked one particular really important state law. It's actually from my home state of Connecticut. The Barnum Act, Barnum as in P.T. Barnum of circus fame. He was the state senator that introduced this bill, which did go on to prohibit the use of contraception. So all of that's kind of in the background for that entire period of time leading up into 1965. So the Griswold v. Connecticut case went all the way up to the US Supreme Court. They actually struck down that Barnum Act that had been passed almost 100 years prior. And that was based on this idea about a constitutional right to privacy. It's really important. We're going to hear that again. But that was really the start of the big swing in abortion care in the United States. That first case, the Griswold case, really only applied to married couples until 1972, when Eisenstadt v. Baird went to the US Supreme Court as well, and they extended that access to contraception to all women, not just those who were married. So again, moving forward a little bit in time, we get to the well-known Roe v. Wade decision in 1973. There was a Texas abortion ban that was across the board, except to save the life of the mother. It was deemed unconstitutional. So it was a 7-2 decision, again, based on this 14th Amendment implied right to privacy. In that decision, importantly, they made comments that the state was able to regulate abortion as the pregnancy went closer to term, that the state interest in protecting the life of the fetus increased as they got closer to that final term gestation, and they were able to ban abortion after the point of viability. It's really important. We're going to talk about viability a lot today, and it's unclear exactly what that cutoff really is. And there's some complex reasons for that, but we're going to keep coming back to that. So in 1992, almost 20 years later, there was a case, Planned Parenthood v. Casey. There was some abortion restrictions in Pennsylvania that were blocked. The Supreme Court at that time made the comment that there had to be a compelling reason to abandon stare decisis, which is this idea that you really shouldn't just keep changing things all the time. You should respect prior decisions by the Supreme Court unless there's a new compelling reason to do so. So then, 30 years later, here we come to the Dobbs decision. As we've briefly mentioned, there was a Mississippi ban on abortions after 15 weeks. This new majority opinion stated that the right to privacy is not specifically laid out in the Constitution, and therefore it is not a constitutional right that is protected federally. They also made the statement that the right to abortion is not, quote, deeply rooted in the nation's history and tradition. People have different perspectives on that statement. I think you could see how the argument could be made in either way. And they reaffirmed the state's interest in protecting the fetus throughout the gestation. And that decision overturned Roe and Casey. So after Dobbs, as mentioned already, there are a number of state laws that were triggered automatically. This is a nice graphic for people who are particularly interested in abortion care. This is from the New York Times. They put the link on there. They keep it regularly updated as the laws have changed. There were 21 state bans that are now in place that have a lower gestational age for abortion access than what was previously established under Roe. There are 13 states in the dark red that you can see here that have total bans except for life of the mother exceptions. There are a lot of cases that are still very actively being worked through the court system as we speak. So there's going to be more to come on that. As we can imagine, there has been significant confusion in the implementation of these bans. There has been a lot of confusion about authority on decision-making. A lot of these laws were designed by non-medical professionals, and the wording in them has been very confusing. Maybe some of that's starting to be worked out a little bit as the cases have come through, but in the meantime, there have been a number of patients who have been really impacted by the lack of clarity in these bans. A couple of quick notes. I don't want to get too bogged down in the data around abortions, but some interesting, important information here. On the left graph, you can see this is a picture of telehealth medication abortions that were provided over the last 3 or 4 years. As you can see, initially, those numbers were really in the kind of 5 to 10% range of telehealth visits for medication abortions. And then, as you can see, after Dobbs' decision, that number has increased quite dramatically. My suspicion, it's not specifically on here, is that a lot of these are being provided to people who do not have access in their home state. So physicians in states that have abortion that is legal are prescribing medications to families who are in states where it is illegal. And those are also actively being fought by a number of state legislatures. So more to come on that as well. There's a lot of complex sort of federal, state, and state-to-state right issues at play there that are beyond the scope of today's talk, but are really important to keep note of. And also really importantly, the graph on the right side is looking at the number of abortions in terms of the gestational age at which they're done. And as you can see here, 93% of abortions in our country are being done in the first 13 weeks. So the vast majority of those are actually medication abortions. And a lot of what I'm going to be talking about today for those with life-limiting conditions are in the small percent on these graphs here. So I just want to point that out. So one of the important things in these abortion laws are that some of them, but not all, do have exceptions for what are deemed fetal abnormalities. The language around that is quite variable. And again, I think a lot of these were designed by non-medical professionals. There's a lot of variation in the language. There's actually lack of clarity that we're going to talk more about here. But some of these example phrases, this fatal fetal abnormality, there's actually not a list that has been agreed upon in any professional organization about what is a fatal fetal abnormality. Same thing with incompatible with sustaining life after birth. Same thing with on the Mississippi law, they say if there is a reasonable medical judgment that, importantly, regardless of the provision of life-saving medical treatment, is incompatible with life. We have come a very long way in neonatology, and we can support life in a variety of ways for conditions that were previously thought to be lethal. And we're going to talk more about that. And then the last one that I added on here, I'm so sorry. For Utah, they actually require that the physician inform the woman that perinatal hospice services and perinatal palliative care are available and are an alternative to abortion. Of note, the availability of perinatal hospice care in the United States is extremely, extremely limited. And that is probably not actually a true statement for most of our patients. Okay, so I want to use this case to try to help us think through what this might be like for some of these families in situations like in the post-Dobbs world. So for this case, I have a pregnant patient, and this is a hypothetical patient who presented at 18 and 0 weeks. That is about the time of when we typically get the first anatomy scan, because that's really the earliest that you can start to appreciate some of the most important organs as they're forming, whether they're forming correctly or whether there's a really life-threatening anomaly there. This fetus was diagnosed with something called a lobar holoprosencephaly. I included some pictures here for those of us who are not familiar with some of these more rare conditions. On the top picture, you have a normal brain. On the bottom, you have the 3 types of holoprosencephaly. A lobar is on the right side. It's the most severe form. And essentially, the brain that is supposed to form into 2 halves with a nice connection in between. As you can see here, there is no separation there. And these children are severely, severely impacted from a neurodevelopmental standpoint. They generally actually result in a stillbirth or a miscarriage. If they survive to a live birth, it's usually within the first 6 months or so that they would die from their condition. These are often associated with other syndromes, chromosomal abnormalities, those types of things. The parents get this information from their obstetric team, and they do not wish to continue the pregnancy, knowing the outcome for their child. In this current state, their OB has very few exceptions on their abortion ban, and the OB is not clear if this meets the criteria for a fatal fetal abnormality. So they do not feel comfortable performing a termination, given that many of these states have significant criminal liability if you perform an abortion that is not fitting within the criteria. So they make a referral to the neonatology team and to palliative care to help this family develop a birth plan. So how do we define a lethal condition? It seems like a straightforward word, but it actually can mean a range of different things depending on who you're asking, what people think about this. In some cases, people mean that it's a malformation that always leads to death in utero. Sometimes it's always leads to death in the neonatal period. Sometimes it's usually leads to death in the neonatal period. And people mean it in all of these different ways. And there's no set definition in this population. And it's such rare conditions. There's a spectrum of outcomes. There's variable phenotypes. We do not have necessarily a clear genetic diagnosis that always has the same path every time. That's just not how it works. So it's really hard. And there isn't an exhaustive list for all of those reasons. In addition, part of what I love about neonatology, particularly nowadays, is that we are an evolving field and we are constantly finding new ways to help children survive what would have previously been a universally lethal condition. Hypoplastic left heart syndrome, which I've got pictured here, is a really good example of this. Prior to the development of surgical interventions that could help these children survive out of childhood, this was thought to be universally lethal, and no interventions were offered for these families. Nowadays, you can take this, on the right side, you can see a diagram of this patient. You can help them reform their circulation so they can actually survive long term. It's a big, hard set of surgeries. So some families do still choose not to go down that route, and they choose comfort care, and that's within the spectrum of permissibility. But it's become so successful that there are people who are starting to question whether that's actually appropriate. So again, we took a lethal condition 40 years ago, and now, is it still right to offer them comfort care pathways? Trisomy 13 and 18, this is another diagnosis that most of us were taught is a lethal condition. It's in the textbooks, even to this day in many places. What data has shown us is that if these children are offered interventions, sometimes intensive interventions like mechanical ventilation and long-term breathing tubes, G-tubes, sometimes just very simple levels of care, they're able to survive. There's approximately 10 to 20% survival at 1 year of life. It's really hard to make the argument that a lethal condition has children who survive even out into their teens. And that's where we are. So that is why this is so challenging. And just as an important note, because of some of the complexities around this word lethal, the lack of clarity around it, and the sort of negative connotations of saying something is a lethal condition, the term is really preferred to be life-limiting conditions now. So if we think back to our case again, we have this mom who is still pregnant. She comes into care at 22 and 0 weeks with this fetus that has severe holoprosencephaly. She has now got ruptured membranes and a fever. Her team diagnoses her with chorioamnionitis, which is an infection in the fluid around the baby. This can progress potentially very quickly into a full septic picture for these moms, so it's very important to manage them promptly. The antibiotics are appropriately started. Her team is doing all the right things. They get the labs that show that she already is starting to have signs of renal and hepatic dysfunction, which is very concerning for a progressive picture that could endanger the life of this mother in the near future. However, the medical team is not sure. Did she cross the threshold? Is she sick enough to perform an abortion? Or do we move to a C-section delivery? Because 22 and 0 is right at the threshold of viability, which in the current state is approximately 22 and 0/7 weeks to 24 and 6/7 weeks. We call this the zone of periviability because it's right in the area where we can save these babies, but there is a significant amount of potential morbidity, high rates of mortality, and it's really important that in these conversations with family that we try to help them understand what their values are, what's most important to them, what they're willing to tolerate in terms of risk for their child, what they're willing to have their child potentially go through, knowing those risks. And in this time frame, it is a shared decision-making process where we defer to parental wishes. So now we have this mom who's 22 and 0. There's a concern that perhaps in the coming years, if we continue down the path post-Dobbs, that this decision could be taken away from this family. That if you are born periviable with signs of life, could we be required at some point to offer interventions to this family, even though this baby has a severely life-limiting condition? This is an active concern. So let's step back a little bit away from the case and kind of try to come up with ways to think about these dilemmas. In obstetrics, the most important feature is bodily autonomy. That is the driving factor of decision-making, because the pregnant individual gets to have decision-making capacity over her own body. We, as a country, still commit to the idea that we cannot violate a woman's bodily autonomy simply because she is pregnant. You cannot perform a C-section over the wishes of a pregnant individual at this time. But again, is that going to change? Is the potential there? I think it might be. And this is really important when we're talking about abortion rights and reproductive rights, that all of these different nuances can come into play in some of these conversations. When you think about the maternal fetal dyad, they can also have distinct interests as a unit separate from the woman. The fetus has their own potential interests that usually, in the vast majority of our pregnancies, they align with the interests of the maternal bodily autonomy. They have the same goals in mind. Sometimes that's not the case. In an ideal world, the fetus is usually best served by staying in the uterus until they're full term. But if the mother is sick, that also affects the fetus. And there are certain situations where the mother's health and life is at risk, and you have to deliver the fetus, even though that's not technically in their best interest. And balancing all of these pieces is part of what is so hard in obstetric ethics. There's a really interesting paper that I've referenced on here, thinking about when the mother comes to care and they present the fetus as a patient. It's not a person, and we're going to talk about personhood here in a second, but it is a way to sort of address providing care to a fetus in the role of patient, because the mother has brought the fetus to care. It's a sort of in-between kind of argument without providing full personhood to the fetus, because when you have personhood, that is a being with independent moral and legal status. That means that there are obligations from society around a person. If we give the fetus personhood rights, there is a major risk that maternal autonomy becomes secondary. There are multiple cases that have already been well documented where life of the mother exceptions are questioned. That's why I use this case, because we've already seen it happen. There have been refusal of prescriptions for pregnant individuals. There have been waiting to provide medical care to pregnant individuals. There have been criminal charges for miscarriages. There have been criminal charges for drug use during pregnancy. This is the slippery slope. Once we start regulating the pregnant individual because she is pregnant and assigning personhood to the fetus, this is the path we can potentially go down. And this is the choice that some states have already started to make. There are many risks associated with criminalizing these types of behaviors. It reduces access to care. People are not willing to tell their doctors and their care teams what they're doing. They avoid care altogether. And that has been well shown in many studies to worsen neonatal outcomes, which is what, hypothetically, we are trying to improve. So I present all of that to you for thought. I am a neonatologist and pediatrician at heart, so I thought maybe the pediatric frameworks might help us here. The best interest standard is our go-to in the pediatric population because we have surrogate decision makers who we ask to try to maximize benefits, minimize risks for the child. The problem is here that often what is right for the fetus, what is the best for the fetus, is not the best for the mom. So we kind of have to pull away from that best interest standard, even though anyone who works with moms knows that in general, that is absolutely what they are trying to achieve. But it's a balance. The harm principle, is that helpful? In pediatrics, we think about that as being the threshold of harm at which parental discretion is permitted. If the harm is above that threshold, outside intervention is permitted. A classic example is often the Jehovah's Witness cases where we provide blood transfusions over the wishes of the parents because the benefits outweigh the risks in that situation, and it crosses the threshold of harm in life-threatening situations. In complex fetal situations, this gets really clouded. Our lack of ability to prognosticate effectively makes this almost impossible to find a threshold properly. So what is another way we can frame these thoughts? I really like this sort of combined zone of parental discretion IPO framework. This is what we really use in periviability and in other pediatric situations when we're trying to situate a specific decision on a threshold or on a spectrum. So the IPO framework is this idea that there are some things that are impermissible, permissible, or obligatory. If you have a treatment that is clearly beneficial, you must provide it. It is obligatory. That is something you would do over the wishes of the parents. A great example I always use is a 2-month-old coming into the ER who is septic and needs intubation and antibiotics. You would override the parental wishes because those benefits are so clearly greater than the risks. You have a very wide permissible spectrum. That's where most of our medical care lands realistically. If it is potentially non-beneficial, that actually still is within the permissible spectrum, so long as excessive harm is not part of that treatment plan. If something is truly physiologically futile, which means that it cannot achieve the stated goals. So if a baby, you put them on, the highest level of support that we have, ECMO, and if there's no way it would help them survive, that is a futile treatment and should not be offered, and would be impermissible in those cases. When we're thinking about our case, our 22-weeker, holoprosencephaly, mom with chorioamnionitis, where does it fall in this decision-making spectrum? If this baby were to be born alive, do we consider resuscitation impermissible, permissible, or obligatory? I would make the argument that in most cases, this is going to be in the permissible spectrum, as long as the parents understand the diagnosis, the limitations of what care will do for their child, the irreversibility of that condition. But at the end of the day, there are some families who having their child alive to meet, to hold while alive is a goal in and of itself. And I think that is a goal that is of value to some families. Would it be obligatory? To me, I would argue absolutely not. We know this is a severely life-limiting condition. We should not obligate a family to do these types of interventions for that type of child. So some other important things that come up in these conversations that I really want to bring out today are these different types of moral distress in these situations. So moral distress is this tension that we feel between knowing the right course of action, but being unable to act on it. For example, families who are seeking an abortion and unable to get it, and now they're approaching the birth of a live child that perhaps they were not financially prepared for. Perhaps they don't have the time to help support this baby. They've got several children. They're working full time. They're caring for their elderly parent, and they're going to have guilt associated with the birth of this child. And helping families navigate these really complex postnatal feelings is going to be challenging for teams. The healthcare teams might also, and certainly do, have divergent views on abortion and when it is okay, when it is not okay, when postnatal decisions are appropriate or not appropriate. And there's a lot of distressing feelings that are associated with these cases and challenging navigation of complex conversations. One of the things that I think is important to consider is that we have this well-established right of conscientious refusal coming out of both the Vietnam War and abortion care. People are allowed to not participate in care that they find morally objectionable, so long as they provide transition to a provider who is willing to do that legal task. I wonder, in this new state of affairs, are there going to be situations where providers will feel the need to do a conscientious provision of perinatal palliative care? If the law says you are obligated to put a breathing tube in a baby born at 22 weeks with holoprosencephaly, are there providers who are going to be willing to step away from the law and provide palliative care in those incredibly hard situations? And how do we support those providers who are potentially going to be put in these situations? We think of this in similar ways in the abortion deserts that now exist in our country. This has been ongoing for hundreds of years. Providers who are quietly doing reproductive care in areas where they're not legally permitted. Are we going to have to continue to try to support people who are doing this? I think this is kind of tied into the telehealth visits that are being offered to people who live in states without abortion rights. It's really important to talk about these types of issues before you're in the middle of a crisis that are often time sensitive. And I'm going to say this a couple more times, but we really, really need more palliative care providers in this country. It is a huge national shortage, pediatrics particularly, and we need training for our staff to help families and healthcare teams get through these crises. On the flip side of that conversation, when we're thinking about perinatal hospice care, you have to have an ethical justification for choosing to forego interventions. It is related to the diagnosis itself. It's related to the prognosis to the best of our ability, the morbidities, the quality of life, the family's goals of care. All of those play into decisions about whether to offer comfort care in the perinatal time period. And as I mentioned earlier, this is not an equivalent alternative to abortion. This feels very different to people in that moment, both the healthcare team and the families. And there are some families who are actually going to make very different decisions. Perhaps they sought a termination during the pregnancy, but the baby is here. We don't know what choices they're going to make postnatally, and we should not be assuming that necessarily they're going to want comfort care. It's very different when you have a full-term baby in front of you. And it's important to understand that and to help families navigate that. And as I mentioned earlier, there's a very limited number of palliative care and even fewer pediatric hospice. There's almost no neonatal hospice care providers in this country. So having that as an equal alternative is a fallacy. I would also caution us against making the opposite decision. So one example, so spina bifida is a very common indication for a termination. Many families make that choice. It is not a life-limiting condition and is not ethically permissible to withhold support for a baby whose only difference is that they have spina bifida. But it could happen that these families who have sought an abortion for many of the different reasons that I described earlier are saying, we can't take care of this baby, we can't meet their needs. I just want to hold them and not do interventions. And we have to think about these before it happens, because it is very possible that some of us will see this. And we have to make sure that we're not letting disability bias lead us astray and to allow ethically impermissible care paths. And that's really hard. I've sort of alluded to this a couple of times. There is potentially a significant number of babies that will be born with life-limiting complex conditions. The CDC estimates approximately 3% of pregnancies, 3 in 100 pregnancies have a congenital anomaly associated. Studies show around 70% of pregnancies with life-limiting conditions are terminated when that is available. In Texas, in the post-Dobbs years, there was an annual increase in 23% in neonatal deaths. So those babies who were previously being terminated are being born alive. They are receiving complex, expensive care in the units, in our hospitals, in homes, in short-staffed hospice care programs in Texas and in other places where abortions are limited. There was a really nice study here that did a bunch of fancy statistics and estimated that approximately 400 live births per year complicated by severe life-limiting anomalies in the United States. So that's what we're looking at moving forward. And that's just in the 24 states that are currently limiting abortions. Pediatric subspecialists, developmental supports are already extremely limited, particularly in rural areas outside of the urban academic centers. Families are having to travel many hours to access any of these care specialists, and nothing has been done yet to address this need that is coming for the pediatric workforce. Will there be impacts on fetal surgery? We have not seen this yet, to my awareness, but the questions arise because fetal surgeries are also occurring in that exact same time frame where abortion is potentially limited. It's the same time frame of periviability. Is it possible that legislation could decide that if a baby were to have complications during the surgery, that you must deliver and resuscitate that compromised neonate, when in the past that was a parental decision? That's possible. Is it, on the other hand, possible that a legislation could decide that fetal surgery is too risky and we simply cannot do it because there is a possibility of fetal demise anytime you do a fetal intervention? Do we throw away all of the progress that has been made improving the long-term outcomes for children who qualify for fetal surgery in the interest of saving a few? I don't know. So this is a talk in and of itself. I've tried to sort of allude to it throughout the presentation. Justice and healthcare disparities are a major concern here. Our healthcare system is quite fragmented already. Limited access to primary care, obstetric care, particularly rural areas where we are seeing OBs leave states that have abortion exemption or restricting trainees in those states that really need them. Safe childcare is a huge problem in the United States, safe, affordable childcare. The role of socioeconomic status is concerning. There is an atrocious lack of paid family leave from the federal level in the United States that affects these families' ability to care for these complex children. The role of race and ethnicity and disparities continues to be exacerbated by all of the above factors. Gender disparities, the lack of reproductive choices, the lack of pediatric subspecialists. Each of these layers of disparities stack onto each other and make life harder and harder and harder for our families that we're trying to care for. In conclusion, restricted abortion access will have downstream effects that could be significant on families and healthcare providers. There is likely to be continued moral distress that is exacerbated by these layering of challenges. Complex cases are going to continue to occur, and we do not have the training and the staff to help care for these families. Will we need to have more support for conscientious refusal or provision of care in these complex situations? We need to train more providers that can support staff and families, and we need to be really vigilant and aware about the exacerbation of healthcare disparities. So here are my references. I apologize, I'm a little over time, Meg. And I am more than happy to take questions.
Thank you so much, Dr. Pyle. That I have pages of questions and thoughts and notes, and you gave us such an excellent background and really opened up some things that I think I'm sure the audience, both online and in person, are ready to ask you. So this was really excellent.
Thank you.
I'm going to just say that for our in-person audience, please note that the microphones only capture audio for our Zoom attendees, and they don't amplify sound in the room. So please speak up so everyone can hear you clearly. I think if it's okay, I'll maybe just kind of start with a first question for you, which relates to kind of the people who are in the room making these decisions or discussing lethality, futility, et cetera. Who, in your experience, kind of who are the specialists in the room, and who do you think should be the people in the room, and how are those conversations happening? Is it kind of case by case? Is it before families come in? Are there working groups to address this in communities? Love to just hear a little bit more about that.
Yeah, and I think that's such an important question. And I don't know that there's a set, definitive, perfect way to go about it. I think every institution is going to have their collection of people that has experience and the knowledge that's needed to try to come to a unified answer. I do worry that in some places, perhaps it's just one person kind of left alone to make that choice, which is really hard. I think in an ideal scenario, you have a multidisciplinary team together with expertise in all of the relevant areas for whatever that child, that fetus is experiencing. Certainly you have your obstetric team, your MFMs, neonatology. I'm biased, but I do think we should be in the room on these conversations. Having palliative care there to help address some of the parents' questions and concerns and help them kind of work through those goals of care. Because a lot of people who have never been in these types of situations have never had to sit down and think about what are their values, what is more important to them in terms of quality of life and suffering, because people feel differently about this. And I think that's okay. We live in a very pluralistic society, and I think it's okay that there's a range of choices that people would make. Certainly having, if you're talking about a fetal surgery, having your surgery colleagues there, if you have a heart condition, having your cardiologist in the room and trying to come up with a group consensus about what would be permissible. And if there's disagreement, I think hopefully most of us have ethics committees available in our centers that could serve as a resource in the most complicated of cases. But I think, in our center, we have sort of our fetal care team that works together in these really borderline cases and tries to come up with a decision together. And if it is more borderline, we'll consult other, member and other colleagues in our field to confirm that, what we're thinking or planning is reasonable.
Thank you. Yeah. Thank you. Any questions in the room? Yeah. Yes, please.
It's interesting that we're focused on what's best for the baby. And in the case that you presented, I did wonder, is an abortion what's best for mom, or is a C-section at 22 weeks with chorioamnionitis what's best for mom, and what's best for her future fertility abilities as well? So that was my first sort of thought, like how we sometimes, I think, dismiss actually the health of the mom in that moment of thinking about what's best for the fetus. And I did want to say that yesterday I noticed on ProPublica a case of 2 forced C-sections in Florida. That the audience might be interested in reading about. I'm afraid your excellent presentation brings out all the reasons why this may become a more common situation. So I should have started with thank you for your excellent presentation, but I will end with thank you for the presentation.
Well, that's tough to hear. I was hopeful that we would still maintain that barrier, protecting, at the end of the day, adult persons of competent mind and capacity to be able to make their own decisions about their own body. I hope that is not the start of a trend. And just to go back to your first comment, it's such a good point. You know, I am not an obstetrician, but I know I speak with my colleagues quite a bit. A C-section at 22 weeks has a number of risks associated, and as you mentioned, has impact on future fertility because of the way the baby is very small. And again, bear with me, I'm not an OB, but the positioning of the baby and the size of the uterus, positioning of the uterus, these are much more complicated C-sections. And generally, these moms have to have a C-section in all future pregnancies because of the way they have to enter the uterus. And that has its own morbidities associated with it. So to your point, you know, probably in that situation, an abortion with a vaginal delivery of the fetus is the safest option in this mom who has a child who is likely to die in a very short period of time. And that is the question, right? So how do we make those choices? And when do we value the potential life of a fetus over the actual current life of the adult woman in front of us?
Another thought I had as you were speaking about kind of this scenario of gathering information and then making these complex decisions is, I wonder if kind of the state where we are now would potentially force patients who would like to get more information prenatally about their pregnancy, let's say by fetal MRI or echocardiogram or genetic testing. Maybe they've been told early on, yes, there might be a problem, and they don't have much information yet, but they are gathering more information. But given the potential options or lack of options that they might have later on, could this in fact lead to some women terminating pregnancies earlier than they would otherwise choose to with limited information? And is that in and of itself another ethical issue that we're facing right now?
Absolutely. Yeah. In short, I think that you've really highlighted yet another challenge when we put these restrictions in place. I know that this happens. I don't know the frequency. I don't know that anyone does. But to your point, if you have a very tight window in which to act, and depending on the state where you are, sometimes those are very, very short, even before the anatomy scans have even occurred. And you don't want to risk it, as it were, as a mother. And you know, the law of unintended consequences. We pass these abortion laws with the intention of leading to more live births of children, right? That is the sort of stated objective, I think, and to prevent the death of a fetus. And when you restrict people's choices, I think you're absolutely right that there are going to be times that people just make an early, quick choice because they don't see, you know, themselves being able to support a child with complex healthcare needs. And again, not an obstetrician, but, you know, we know there are false positives all the time in medicine, and that applies to obstetrics as well. You know, this non-invasive prenatal testing, which has been revolutionary in obstetric care in the last few decades, has a fairly reasonably high false negative rate, who are leading families to not get later testing and what would have been potentially a healthy newborn.
I'm going to take a question from online. I know of a situation in which a hospital attorney has decided that all 22-week, 0-day infants and above must be resuscitated, and palliative care for these infants is not allowed. This decision was made on the laws defining personhood in fetuses after a heartbeat can be heard and preventing abortion after a heartbeat can be heard. The neonatologists are not comfortable with resuscitation against a parent's preference. What do you suggest these neonatologists do?
That sounds like a very tough situation. I'm sorry to hear that. This is the fear, that this is the steps we are taking. I had heard anonymously of similar situations that were potentially unfolding. There was actually a law passed, I forget what year now, the Born Alive Infant Protection Act. There was a lot of concern that this was going to lead to this exact situation that's being described. The idea is that if an infant is born alive after a late-term abortion is how it was sort of framed, but it was thought to maybe apply to all infants born with any signs of life. We are required to use our medical skills to help them. It ended up not going anywhere or doing anything. There were no associated repercussions in that law. I would encourage the risk and legal team involved to really have more looks at the law and what it actually says. There have been attempts to add teeth to that law that have been in the Senate, I think, for 20 years now and have not gone anywhere. There are very good guidelines from the American Academy of Pediatrics, from the OB organizations that all universally support a shared decision-making process during periviability. Those are well-established, well-researched professional guidelines that support the neonatologist perspective in this case, saying that it is a parental choice because the risks of morbidity, long-term, potentially profound neurodevelopmental impairment, that it really should be the parental discretion, as it would be everywhere else in pediatrics. We really defer to parental choice when there is so many known risk factors. And this really shouldn't be different from that.
Yeah, absolutely. A lot of moral distress in that situation for sure. Yes.
I'd love to follow up on that question, which is this idea that you arrive at a hospital and there's different policies at a different hospital, and the public isn't aware that the hospital attorney at this hospital thinks this, but the one over there. And we know, and maybe you could speak to this, about even neonatologists in the same hospital with different perspectives on some of these things, and what a patient could do, or what you would recommend to patients as they sort of, if they're approaching a pregnancy with this sort of thing in mind.
Yeah, this is so great question. Thinking about, this lack of clarity for patients who are going to different hospitals that have different policies, almost none of which are publicly available. This is seen in other areas in neonatology. I was actually involved in writing and publishing or sharing with our patient population a guideline for trisomy 13 and 18, because to your point, when you have an institution that has different even providers within the same unit who have different feelings, you could be born on a Tuesday and have a different care plan on Wednesday. And that is so clearly unjust that it has to be addressed. So I would really encourage any neonatologists who are still out there, or people who care for obstetric patients, that you have a defined written policy that you share with patients early on so they can make decisions, because there is inter-provider variability, there's inter-regional, inter-hospital variability. We, even outside of the abortion discussion, periviability continues to be a hot topic, because some places will not resuscitate at 22 weeks. Some places obligate resuscitation at 25 weeks. And there are a couple places in the United States that are starting to offer resuscitation at 21 weeks. There is variability, and some of it's based on good data, and some of it is based on feelings. And I think it behooves all of us to, just from a self-protection standpoint, to help prevent some of these dilemmas from arising in the heat of the moment. Like, have a plan, write your guideline, share it with your providers, share it with your patients, be transparent.
I think it also too just highlights the importance of patients advocating for themselves from early on, and hopefully their physicians telling them to advocate for themselves. Just adding one more thing for patients to do, but I think the importance of that and asking those questions either prior to pregnancy or during pregnancy is becoming more and more important in the landscape that we're in right now, for sure. Any other in-person questions? I'm just going to look. Yeah, we have one in the audience over here.
Hi, I'm a social worker. I don't know if this is on, but I'm a social worker. So what keeps coming to my mind, this has been so fascinating and so much to think about, but what of the moral distress that the doctors experience being told by governments and with laws of how they're supposed to treat their patients, you know, the baby, the fetus, the parents, like that. It must be so difficult to deal with the moral distress that I think might be there.
Yeah, no, I think you're spot on. And the moral distress factor is very real. In the world we live in today broadly, the way healthcare is practiced specifically, from every direction, you know, from governmental regulations, from the financial side, from the strain our patients feel socially, all of these different pieces just layer onto one another. I think there has been increasing recognition of moral distress as a problem, and there are some institutions that are really working hard at trying to find better ways to support their staff. Burnout has been identified as a major problem in healthcare. I think there are some initiatives that are showing some success at trying to help alleviate some of those symptoms of burnout, but it continues to be incredibly challenging and contributes to the shortages that we're already seeing in healthcare. So I think it's so challenging, and you know, our social worker is such a critical part of our NICU. So thank you for the work that you do. You're really able to help get down to some of those pieces that are harder for us on the medical team side. So I'm incredibly appreciative to our multidisciplinary team approach to these families and their many, many needs.
I can imagine too, you know, being a trainee in this environment must be incredibly challenging, as well as being you know, teaching in this environment when there is so much uncertainty and moral distress all around, really.
Yeah,
So
absolutely. And, you know, it's a constantly evolving landscape. So it feels like even as I was preparing the talk, you know, things are coming out, actively changing what I thought I knew. And it's hard to imagine being a student when everything feels unstable. I guess I'm grateful to have finished my training a decade ago in that way.
anybody else in the audience? Okay. All right. We are. Do we have time for one or two more questions? One more question. Okay. Great. This is a question about in the case of a surrogacy pregnancy. You know, essentially, I'll summarize here, but kind of who should be making the decision about the intended parents or the gestational carrier? So how are these pregnancies decided and deliberated, and how is that different?
Ooh, we're gonna end on a really tough question. So that's such a great question. And I think so, again, layers of complexity. I think I don't have a perfect answer to jump forward to that. It does seem as though it is critically important in surrogacy setups that these are talked about. You know, I think as we have learned more and more about surrogate pregnancies and do them more often in medicine now, we understand that you really have to discuss things in advance. I think there's such risk to the surrogate if that is not made very clear. There are certainly cases where they were asked to undergo a termination when a lethal anomaly was found. And that can be really challenging for the individual who has agreed to participate in this agreement, and it is not their genetic offspring, but, you know, there are feelings associated, there's moral distress associated with that. I think in most cases, many of the decisions are driven by the intended parents, but I would say it would be ethically impermissible in my view, to perform interventions on the surrogate's body without her explicit permission. So at the end of it, she could still make the choices governing her own bodily autonomy, even if it were against the wishes of the intended parent. So that would not be a case where I think it would be appropriate to perform a C-section over her wishes if the intended parents wanted it. I still think, to me, that is a bright line in the sand. You know, we have autonomy. We are permitted to say no to even life-saving measures because we have autonomy as long as capacity exists. But those are really, really challenging.
Yeah. Well, that's a great note to end on. Thank you so much for all the information that you provided us today, and so much to leave and think about. Thank you, Dr. Pyle, for your presentation today. Thank you to our wonderful audience for all of your thoughtful questions. The recording of this event will soon be posted on the Columbia Division of Ethics website. Our next Grand Rounds will be on April 17th with Dr. Ashwin Vasan. Use the link in the chat to register for this session. In the meantime, please subscribe to the mailing list to stay up to date on details of our upcoming events. And for those joining in person, please complete a brief survey to provide your feedback on today's events. Surveys can be found at the back of the room on the table. And for those online, a brief survey will automatically display on your screen once this webinar ends. We appreciate that so many of you joined us today, and we hope you have a wonderful week.